right. Thank you very much. This morning, we are going to take a little journey down prostatectomy lane. And I'm going to basically tell you where we've been. I'm going to tell you where we think we're heading. And then I'm going to tell you where we're actually heading. Radical prostatectomy. It's been around for over 100 years. Started with a perineal approach. Then 40 years later, we went to a retropubic approach. Of course, major advance was the nerve-sparing prostatectomy, and now we're living in the era of laparoscopic and then robotic prostatectomy now. All of these sort of incremental advances have been in this goal of something called the trifecta, which is to achieve perfect cancer control, but not leak urine, no incontinence, and no sexual dysfunction. That's the trifecta. More recent literature might also talk about the pentafecta, which you add to the trifecta negative surgical margins, that final pathology, and no surgical complications. It's a little bit of a mythical goal, or something that you work towards, and I'll tell you why. The question is, of course, how have we done? And I think it's fair to say that some things have been good, and some things not so good. This is an important study, published in the Journal of Urology, very well funded study, taking 11 of the top high-volume centers in the United States, looking at the outcomes of radical prostatectomy on a long-term basis, and comparing both open to robotic outcomes. And it's very fascinating because this paper really, in my opinion, didn't quite have the impact that I think it should, because it's quite provocative what the findings show, which is essentially that you've seen some major advances in the robotic era, and we can all agree in our own patients that you don't see bladder neck contractures anymore, people aren't getting transfusions, length of stay in the hospital is less, and these are all very important things. What's also very interesting is surgical margins are still, in this study, 20% surgical margin positive rate, hasn't gone down to zero. What's really interesting, of course, is if you look at the quality of life outcomes, right? Again, the trifecta, we're looking at urinary incontinence and sexual function. Well, again, if you look at these curves here, and we're looking at time zero, people take a hit immediately after surgery, and then it gets better over time. But certainly, if you look at the top curve, and that's looking at urinary incontinence after prostatectomy, it literally looks like the same curves. Just so you know, the orange is the open surgeries, and the blue are the robotic surgeries. It's literally the same curve. So your conclusion, number one, is that you definitely have incontinence after either one, open or robotic prostatectomy, but literally it's about the same whether you do it through an open approach or through a robotic approach. Sexual function is even worse, and again, we all kind of know this in practice. You start at a certain level, your erections definitely take a hit with prostatectomy, whether you do it open or robotic, and then it comes back a little bit over time, but definitely there's a lot of hope in there. And the actual final rates of erectile dysfunction at study end at 2-year point, they're pretty bad. If there's a difference, it's actually because if you look at the curves, the reason that line splits is because the better cohort got a nerve sparing. So clearly nerve sparing is important, but of course not enough to restore you back to where you were before you started. So this is, again, very provocative. Now, before you start thinking, well, it's just those, American surgeons are somehow not very good, we can look at basically the data that comes from the United Kingdom. This is a study looking at the first-year outcomes after robotic prostatectomy. In this cohort, over 2,000 patients in 26 centers in the UK, at 1 year, about a third of patients were still using pads. And it's interesting because this study actually took the pains to put it into the patient's friendly language. A lot of times we hide behind our questionnaires and our quality of life forms. Actually, they just asked straight up, very, very simply, are you wearing a pad or not? And about a third of them said yes. About 90% of them are having erectile dysfunction at 1 year, with or without taking a pill. So these are pretty much, again, there's good news and bad news. And bad news is, functionally speaking, men are not doing very well. And again, it's not just the Americans and the British. We're talking about data that has come out all over the world, right? So you've got Sweden, you've got other European papers, you got Sloan Kettering, you got Australia. Study after study that looks at the longer-term outcomes of robotic surgery have shown that even for intermediate risk cancer, we have not seen the sort of improvements that we would hope to see. So if we think about that trifecta, right? If you look at the literature, of course, the literature reports different rates, but if you really use strict criteria in the literature, the chance of achieving that trifecta after robotic surgery is about 40%, okay? And in the pentafecta, let's just say, that rate is gonna be even lower. Well, look, if you're a Major League Baseball player and you hit 400, you're an all-star. But if you're a surgeon and you've got the future life and quality of life of a man's hands, a man's future in your hands, batting 400 is really not great. So this has kind of given rise to the era of active surveillance. And of course, this actually is a bit of a reaction against the era where we used to just take out prostates for Gleason 6 cancers and leave people impotent and wearing diapers. But you have to kind of understand that active surveillance, while appropriate and kind of the smart choice in terms of we're not messing people up by treating them, I find it to be a bit of it's playing defense. No offense, Mr. Wheeler. You're basically just trying to manage it, but try not to do something that'll harm them more. But I think we also have to acknowledge that active surveillance itself actually does have risks. And of course, the risk of doing a biopsy multiple times over someone's lifetime is one. But how about actually the psychological burden? And I think that's really underreported. I've written about PSA anxiety, others have. It's a little bit like asking us today in the audience today, are we happy today? Or if I'm asking you, are you happy today, this morning, because you could be even sadder. We're basically defining the result based on a negative outcome. So, with every PSA, every MRI, you're waiting for the other shoe to drop, much less your next biopsy result. And that has an actual real impact on, quality of life as well. So you'd like to think that there is some middle ground, right? Prostatectomy, active surveillance, middle ground. Well, that's where focal therapy is meant to be, right? And I think there clearly is a role for focal therapy, but focal is how we define it. And I think it's also fair to say that certainly a limitation of truly focal, like treating one focus of the visible lesion, is that we know that over time, prostate cancer is a multifocal cancer. And therefore, if you're truly doing really targeted focal therapy, well, then you just have to be honest with the patient that you are, maybe likely to have multiple treatments over your lifetime. And of course, every treatment that you do, no matter how minimally invasive, carries some risk. I often get the question, why can't you just take out part of the prostate? Meaning during prostatectomy, why can't you just why can't you just cut out the part that has a cancer? And it's actually, to a patient, that makes a lot of sense why you ask that question. So guess what? Dr. Menon has been doing this, right? It's called the Menon Precision Prostatectomy. And of course, Dr. Manny Menon, excellent, very skilled surgeon, the father of modern robotic surgery, prostatectomy. So he can go in and basically subcapsular, spare the non-venous fascia, spare the capsule, and basically just take out the part of the prostate that is affected, as opposed to taking out the whole prostate. And I think this is intriguing as a concept. Whether in practice it's something that's feasible, I think there are some limitations, right? So, number one, Dr. Menon is an excellent surgeon, and he is able to do that. Not everyone is as skilled as Dr. Menon, but I consider myself an excellent surgeon. But when you go and you cut into the prostate, it doesn't look like this, right? It looks like tissue. So you're actually just using anatomical landmarks to try to know where it is. But it's not like there's a big sign in there that says tumor is here, tumor is not here. So this is the problem, is if you cut into the prostate, you're committed, and you're still having a major surgery at that point. So this is kind of where, this is where we've been, and this is where we are trying to go with robotic technology. Well, I'm just going to remind everyone that all technologies has a life cycle. And of course, CEOs understand this. There's a time for the rise of your company, and there's a time where eventually your company will go out. And even Jeff Bezos says that about Amazon. So I think that what's really interesting then is, of course, this theory of disruptive innovation, right? And this happens all around us. So if you think about cassette tapes, well, they evolved and they became the CD, and that was even better, higher fidelity. But actually, the people who made those CDs are now bankrupt because you had this thing called Napster, and then now what do? We all listen on Spotify, Apple Music. So you've had a disruption of that industry, and none of the incumbents saw it coming, okay? Because they were just busy really making a really good CD. Well, I'm just going to pose this to you then. Is it possible that we are at the cusp of the second curve, where we are at the tail end of the robotic era, and we're ripe for a new disruption in technology? And I think that if you're living in that moment, it's really hard to know you're in that moment, okay? It's kind of like Ernest Hemingway, said about bankruptcy, right? It happens slowly at first and then quickly, right? So you don't really know until literally all of a sudden now there's this new technology and you're bankrupt. Well, okay, let's think for a second then about what we're doing with TULSA. What we're doing with TULSA looks a lot like the Menon precision prostatectomy. It's just we're not making any incisions, okay? And of course, the TULSA didn't just come out of thin air. There's a lot of people, really smart people, a lot of them are in the room today, who have done really good studies to validate the fact that what you see on that screen is actually happening in the body. And that's always that leap of faith that even I, like 200 cases on, I always try to believe this is science fiction stuff. How is it possible that this thing that I see on the computer screen is actually happening inside? Can I trust that? So I find that to be like, this leap of faith that you have to have as a surgeon, especially one that, is used to doing prostatectomy. But this is all validated, well done studies that have paved the path, over the last over 10 years to know that what we're doing on the monitor is actually happening inside the patient. So for example, these are great studies. You ablate, and then you take out the prostate. And then you look under the microscope and you see where that ablation zone was. Well, the first study just tells us, hey, we killed the cancer. And then the second study will show, okay, actually you can kill it all the way out to the capsule. Well, that's important too. And then the third study is really interesting too. This third slide image, that one they treated, and then they waited, and then they took out the prostate, and 3 weeks later you could actually see where beyond the treatment zone you actually get additional cell death, right? And that's important because if you're trying to do nerve sparing, you got to know how much margin do you have, or if you want to make sure you get the cancer, how much margin do you need to go beyond the visible lesion? So these are all really good studies that have been done and paved the path for, of course, the TAC trial, right? So this is the pivotal trial. It led to FDA approval, 115 men, mainly intermediate risk cancer, and multi-center trial. So this, obviously when you're doing FDA approval, you need to show safety and efficacy. Well, clearly this was safe, right? So guys were getting whole-gland ablation, meaning bilateral treatment, and, very few complications, right? Very low rates of infection, stricture, all the things that we might worry about. But on the cancer side, pretty good, okay? So it was showing, at biopsy at 1 year out, about 80% of guys had no cancer, but that also means that it was, 20% not effective. Now, on the functional side, though, it's pretty incredible, right? 87% of guys kept their functional erections at study end, and 92% were pad-free. Of course, the skeptic in me looks at this data and says, what the heck? Why are 8% of guys leaking after the TULSA as well? Because that doesn't sound great either, okay? And why is it that we have a 20% non-cure rate? Well, I will tell you, I know several of the people who are involved in the trial are in this room. What I will say is that I don't think this is the version of the TULSA that happened for the TAC trial is not the version of the TULSA that we do today. As you can imagine, there's been a massive evolution in protocols and how we do the TULSA, the actual device itself. This was done on prototype, but now we have different AI and all that. So I would basically say, and I can just speak to my data, I think my data is definitely better than this. And I would say that continence rate is basically going to be less than 1%. So anyhow, I think, as well, others will talk about the Captain trial. As we get more modern data, we'll get updated results. So what does this look like in real life? Well, this is a 73-year-old guy, and he had been on active surveillance, but his PSA was going up. He also had BPH, by the way, 62 grams prostate. MRI showed lesions, right? Pyrus 5 lesion, Pyrus 4 lesion, but importantly, bilateral disease, and on the left side, looks like it was possibly getting extracapsular or getting close to that. He had a targeted biopsy that showed Gleason 3+4 in that targeted lesion. But again, sometimes, even on targeted biopsies, maybe it is more, aggressive and you don't quite know it. This gentleman actually came to me because, of course, he wanted TULSA, and I basically told him all the reasons he should not have a TULSA. Well, yeah, there are real reasons why you don't go do a TULSA. For example, he had tons of calcifications that could have caused a problem, right? Calcification blocks the beam energy. You can't get to the cancer behind it. Even more importantly, he had a hip replacement, right? That's usually a contraindication to do TULSA, or at least, and that's because the hip artifact will kind of mess up the way that you need to treat. But also, it's maybe okay if the lesion is on the contralateral side, right? Right hip, but he had only a left lesion. We're only going to do that focal. No, this guy, he had right-sided cancer. So it's like, I basically told him, look, if you can't force men to do something that they don't want to do. He didn't want prostatectomy, and he didn't want radiation. So I basically just told him, listen, this is what I think I could do in the best of my hands, and we're just going to see where the results go if that's where you insist. Well, we ended up doing a whole gland treatment. Thankfully, the right hip actually ended up not being as much of a problem as, and there are some things that you can do to try to minimize that artifact. But importantly, we went wide on the left side, kind of shown by the arrows there. That's where, those are the pre-treatment images. But we definitely wanted to account for it. But the key point here compared to prostatectomy is that you can see things, right? So before, when I cut into the prostate, I don't have X-ray vision. This one, we have MRI vision, if you will, okay? So I'm happy to report that he did great, no post-op issues, but actually he's now over 2 years post-op. His PSA, his latest PSA was 0.65. His MRI, of course, shrunk down to 22 cc's. He's very happy about the urination aspect of all this as well. So he's very happy. This is a 61-year-old guy. PSA not that bad, 6.92, but he definitely had a nodule, and he had a biopsy done with someone else, and he came to me with basically a presentation of Gleason 8 and 9 cancer, of which he was rightfully told. You should be on, you should get a radical prostatectomy, and then, of course, potentially consider even adjuvant therapy and things like that with hormone therapy. He came to me and said, I would rather die than have those things done to me. And again, he's an active guy. He's a veterinarian, and he loves his animals. And the thought of the functional outcome of all that stuff, basically, he was like, no way, I'm not doing anything. Again, these are one of these cases where you're like, okay, well, this is not the standard of care, but if this is what you want me to do, I will faithfully try to do the best I can. And so we ended up treating him. And this is we did a whole gland ablation. The index lesion, as you saw there on the PSMA scan, it was on the left side, so we paid special attention over there. We did some nerve spinning on the right side. But look, it's a whole gland treatment, and the goal is to eradicate cancer. Well, that was almost 2 years ago. And his PSA went to 0.33 post-op, and it's been stable since then. We've been following him like a hawk. His MRI has been negative at 4 months, 10 months, 14 months. He's at 81% gland reduction in size. Most importantly, he's happy, okay? So go back to that active surveillance patient. Happy, not happy? This guy's happy, okay? Every time he comes in the office, he's showing me how happy he is. Like, he brought in like a personal greeting from his, celebrity friend, and he brought in like a prostate cake for my staff, and the bow tie I'm wearing today is actually from him. So I just want to say, this is how we impact people's lives, okay? He escaped incontinence. He has some erectile dysfunction because of the non-nurse sparing part on the left side, but he's quite happy about it. This is actually another guy, also 61, not the same guy. And his PSA was climbing, biopsy done by someone else, but he presented to me with Gleason 8 cancer. And you can see on this MRI, he has, PIRAS 5 lesion. So the one on the right is a large anterior lesion, and that's PIRAS 5. That was his Gleason 8 cancer. But he also had a Gleason 4+3 on the right side. You can see that one's the MRI on the left. So a smaller lesion on the right side, a big lesion on the left. Obviously told to do prostatectomy. He's like, look, I go hunting. I'm off in the woods for a month at a time. I'm not having a prostatectomy. I don't care what happens to me. Again, this is just real world. So same thing. Hey, look, you know what we're about to get into. I can't promise you anything, but this is the best we're gonna do. So we did it. This is one of my later guys. He's now 9 months post-op, and his PSA went down to 0.23. He's been stable. His first post-op MRI was totally negative, meaning no lesions. He's had a 73% reduction in his volume. But he's had zero incontinence from the beginning, okay? But actually, I wanted to show you his shim scores in his writing, okay? This is sexual health, inventory score. This is him pre-op. He was 25, which is perfect, okay? This is post-op, literally perfect, right? So it's literally unchanged. And, he has had zero erectile dysfunction from day one. If somebody had come to me for a prostatectomy and they told me at 9 months after prostatectomy, you're likely cancer-free and you have zero leakage even from day one and you have zero erectile dysfunction from day one, I'd be like, I don't believe you. And if you do, that's a minor miracle. Well, we're doing these miracles, and this is the TULSA. This is how powerful the TULSA is. So when I see this stuff in the real world, to me, it's like, whoa, how can you go back to doing prostatectomy? Now, I'm not saying everyone should go do TULSAs on Gleason 8 and 9 cancers, but I'm just saying this is what the technology can do. Now, it's really important to spend a lot of time, right? Because you got to counsel the patients appropriately, manage their expectations. You don't want to promise the world because, hey, I don't know if we can always deliver the world, right? But you sit them down, and the funny thing is when I counsel for prostatectomy, it's like, even if I tell them, oh, I'm going to do nurse sparing, I'm going to not mess you up, actually, you don't really know. So, you don't have that much of a discussion with them. On TULSA, you sit them down, and you say, okay, I could do this focal. This is what it means for you. Or I could do this, hemiablation. This is what it means for you functionally. Here's your risk of incontinence and erectile dysfunction if I do it that way. Or if I go Whole-Gland, or if I go Subtotal. This is what I think is going to be your rough percentage chance of leakage of urine and erectile dysfunction afterwards. And every patient is different because it matters where their lesion is, where the other proximity of the other structures are going to damage, how effective, how far away from the urethra it is. There's all these little variables that you will be thinking about when you counsel the patient. But once we mutually decide on that treatment plan, that's what I carry out. And it's with full informed consent with everyone involved, myself, the patient, maybe the patient's spouse. But it's just it's a phenomenal level of buy-in from both sides instead of this just top-down, like I'm just going to do this bilateral nurse sparing, wink, wink, prostatectomy thing. To me, this is actually where the future's going. Now, I think. So again, it is a lot about the education, expectations, and even what the risk of recurrence is going to be, and also then your rate of retreatment, possibility of retreatment afterwards. It's entirely possible that people want focal therapies, and then that's okay. Then you just say, well, if another lesion pops up in the future, you can always do this again, or even other focal therapies if you want to. So then if you want to play whack-a-mole with each new tumor that comes up, you could do that too, right? So I think it's just important to think a little bit outside the box here. It's like, well, then maybe what we are heading towards is the era of MRI-guided precision prostatectomy. And prostatectomy, we put that in quotes, right? Because you can customize whatever you want to do with the technology that's available. And we're able to faithfully carry that out with zero essentially almost zero complications, but really massive improvements in that quality of life outcomes. And by the way, you're avoiding the toxicities of the other things you would need to do to get there. For example, even androgen deprivation therapy and other side effects. So we'll allow ourselves to actually dream big, okay? Maybe the subtotal / whole-gland TULSA is the new standard of care. But we just don't know it yet, okay? If you allow yourself to think that for a sec, I mean, look, we obviously need the data. Well, the captain trial is gonna give us a lot more of that data. It'll eventually make it into the guidelines as well. But if you remember back when we transitioned from open to robotic, of course, mani-mani was a big deal, but it actually was patient-driven, okay? And patients drove the volume of the robot because they perceived that it was worth it, right? To have a better quality of life. Now we see from the papers 20 years later, unfortunately, we didn't get those gains from the robot. Well, I think that the patients have already figured it out, just like Mr. Wheeler figured out. You know, patients are already coming in, they already know things, and it's really important for us to put the right information out there and not let misinformation be out there so that when patients make their own informed choices, that they can do it based on the evidence that we have already accumulated. I'm here to tell you that a urologist can become a TULSA surgeon. So, those 200 cases that I talked about, I've done that without a radiologist. And, it does take multiple leaps of faith to be able to read your own MRIs and then do a treatment based on that. But at the end of the day, I will tell you that, it's not just the TULSA or the day of the procedure. It's all the preoperative planning and then the postoperative stuff. But when you're in that OR, I think of it as an OR. It's not an imaging room, okay? And so, when a patient's under anesthesia, we move fast, and there's not a lot of chit-chat at my center. And you know what? I mean, I'm not a mean guy, but it's like I don't really need to talk about your week. What I'm really focused on is making sure that this patient doesn't spend an extra minute under anesthesia that is wasted. Okay, and that's how we can use the same principles from robotic surgery to the MRI surgery suite. That's where I do routinely do 4 TULSAs in a treatment day, and those are whole gland TULSAs, and each one of those, if I need to do a second segment, I'm going to do it. It's just you're just reaching the efficiencies to get the best outcome. So I would say look, I think it's maybe time that instead of playing defense, this is what offense looks like. Okay, this is what it looks like to actually go and be proactive and then actually take care of a problem and let guys move on with their lives. So that's the future that I envision, and I'm excited to see if it happens. Thank you very much.